Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled State Workforce Strategies in Response to COVID-19, Experiences from the Field, and it took place on May 21st, 2020.
Okay, well, welcome to our webinar on State Health Workforce Strategies to Address COVID-19. I am Patricia Pittman, I go by Polly, and I direct the Fitzhugh Mullan Institute for Health Workforce Equity at GW, which houses our HRSA-supported health workforce research centers. I'm joined today by my colleagues in 5 other universities around the country that lead 7 additional health workforce research centers. We're very grateful to HRSA and in particular to Dr. Luis Padilla and Michelle Washko for this opportunity to talk to you about health workforce policies we see emerging around the country in response to this unprecedented national emergency. Specifically, we would like to talk about 4 different areas that we see as sort of categories of actions that states have taken. First is data. The whole issue of data, health workforce data for decision making has really risen to the fore, and we are receiving requests from states to provide data for decision making around the pandemic. The second is surge emergency policies to essentially increase the size of the workforce. The third is emergency policies that enhance the flexibility of the workforce and the adaptability of the workforce. In other words, who does what and in what kinds of settings. And then fourth, we'll talk a little bit about resilience, or what some people may call sustainability, which includes both the standards to ensure safety of the healthcare workforce as well as programs to promote well-being and job security of the workforce. If we have time, we'll also tell you a little about what some of our health workforce research centers are doing in response to COVID-19. So while we'll be primarily talking about the first phase of this pandemic, I also wanted to share a slide that Dr. Erin Fraher had forwarded on. It has been circulating on Twitter, and it talks about 4 phases of the pandemic. And we will be focusing to a large extent on the first phase, but it's important to recognize that even after the peak of the infections, there will be repercussions for the healthcare workforce and the health system more broadly. And so to the extent that we can in the discussion center, we'll talk maybe a little about what the future holds in terms of waves 2, 3, and 4. Hopefully not waves of infection, but essentially the sort of trickle-down effects of this pandemic on the rest of the system, which are quite distressing. So before inviting our other panelists to review state actions, I'd like to introduce Dr. Padilla. We're very fortunate to have Dr. Padilla leading the Bureau of Health Workforce at HRSA, and he will be providing some context for us in terms of what the federal government is doing, and in particular HRSA, around these issues. Dr. Padilla?
Hi, Polly. Thank you very much for that introduction. Thank you. And I'd like to thank all of our health workforce research centers for their efforts during this pandemic. As you all know, this extraordinary pandemic has caused us all to pivot our work, and I've certainly been very proud of the research centers and the way that they've been able to pivot, and the extraordinary products that you've put out to help inform policy and planning leaders to country and states and local areas. So thank you very much. I'm pleased to participate today in today's webinar and learn more about how states are responding to the COVID pandemic and the research underway to support health workforce planning. At the federal level, HHS and HRSA are helping to lead the nation's ongoing response to this unprecedented pandemic. And as you know, HRSA plays a critical role in improving healthcare to people who are geographically isolated and economically or medically vulnerable. And now more than ever, this is a critical mission and a need that HRSA fills in for. Across HRSA's bureaus, we have made significant awards to address COVID, and I wanted to highlight a few of those. HRSA recently awarded $583 million to HRSA-funded health centers in all 50 states, DC, and the 8 U.S. territories to expand COVID testing. HRSA also awarded nearly $165 million to combat the COVID epidemic in rural communities, supporting small rural hospitals and additional funding to HRSA-funded telehealth research centers, TRC, provide technical assistance on telehealth to help rural and underserved areas combat COVID-19. HRSA also awarded more than $1.4 billion to health centers across the country to help communities detect the virus, prevent, diagnose, and treat COVID-19 infections, and maintain or increase capacity and staffing levels. This historic epidemic has placed on HRSA an extraordinary responsibility. HHS has directed HRSA last month to oversee the Provider Relief Fund, which will help support providers that have been struggling and have lost revenue as a result of this pandemic. On April 1st, HHS was charged with managing over $175 billion of funds that was set up by Congress that is nearly 17 times larger than HRSA's annual budget. As I said, these federal dollars will provide relief to hospitals and other healthcare providers on the front lines of the corona response. The funding will be used to reimburse healthcare-related expenses or lost revenue attributable to COVID-19 and to ensure uninsured people are tested and receive treatment. Additionally, on May 15th, HRSA awarded $15 million to 159 organizations across 5 health workforce programs to increase telehealth capabilities in response to COVID-19 pandemic. These investments will train students, physicians, nurses, physician assistants, allied health, and other high-demand professionals in telehealth and enable them to maximize telehealth technology in response to COVID-19. And in regards to telehealth, I just wanted to highlight another HHS resource, the telehealth.hhs.gov. And through this website, organizations will be able to maintain primary care services when clinics and medical facilities are not available. And this is especially valuable for COVID-19 positive, quarantine, elderly, and other vulnerable patients and people. More details on these can be found on our website, so I encourage you to take a look at those resources. Within HRSA, the Bureau of Health Workforce is responsible for strengthening the health workforce and connecting skilled providers to communities in need. We know the pandemic is taking a toll on our frontline healthcare providers, and I'm pleased that some of today's discussion will be around health workforce resilience, an important part of post-COVID recovery. Ensuring the availability of healthcare providers is key to addressing the immediate pandemic response and future recovery efforts. As you know, BHW is home to the National Center for Health Workforce Analysis, which serves as national resource for health workforce research, information, and data. And as part of its mandate to provide national insight into health workforce planning needs, NCWA oversees our cooperative agreement with our 9 health workforce research centers, including the Health Workforce TA Center in New York. Research, evaluation, and community insight are critical in addressing the pandemic and to better understand how to develop responses that support our health workforce and those most affected by the pandemic. The Health Workforce Research Centers play a key role in understanding the workforce implications of the pandemic and evaluating state strategies. Forums such as today's webinar play an important role in highlighting best practices, lessons learned, data, and emergent research that can help to shape the response and recovery efforts of our partners at all levels with the ultimate goal of helping to save lives. I'd like to end by thanking all of you once again for joining the webinar and thanking our Health Workforce Research Centers for all that they've been doing during this epidemic. Thank you. Turn it back to Polly.
Thank you, Dr. Padilla. That was very helpful to understand the context, and clearly you all are working 24/7 as well. So hats off to you. So next slide, Dave, if you would. I'd like to introduce our panelists. First, we have Dr. Angela Beck, who leads the People Health Workforce Research Center at the University of Michigan. We have Dr. Erin Fraher, who leads the Carolina Health Workforce Research Center at UNC Chapel Hill. Dr. Bianca Frogner at the University of Washington Center for Health Workforce Studies. Dr. Jean Moore from the Center for Health Workforce Studies at the University of Albany. And Dr. Joanne Spetz from UCSF, Health Workforce Research Center on Long-Term Care, among many other duties that she has at UCSF. Myself, and Dave Armstrong, whom I'd like to recognize and express appreciation to for organizing the webinar. He leads the Health Workforce Technical Assistance Center. So we have about 45 minutes left, and I'd like to leave some time at the end of the hour for general discussion with our audience. So we'll try to keep our responses short and hopefully have an opportunity to circle back on some of the issues that are of special interest to our audience and have a deeper conversation about those. So before we talk about sort of the major categories of state strategies, I know that many of you were contacted by your respective state governments and asked to help with different things. And I think it's interesting just to sort of put in context the work that you all are doing in states to understand sort of how it's valued by the state government. I'd like to start with you, Erin.
Sure, and thanks for the chance to be here today. I really appreciate it. I'm going to start by saying the state government came to us really for 2 things. They needed data and they needed access to our trusted network and relationships with health workforce stakeholders around the state. I'm going to talk quickly about each of those things. First of all, one of the things that I reflect on about this whole period is that emergency preparedness really requires data that has already been housed and analyzed. Because as you mentioned, we sort of need to have immediate data on the size and location and the clinical capacity of the existing workforce. So we were really lucky in North Carolina that we've been housing data on 21 health professions for over 40 years. And that resource turned out to be incredibly helpful because we were quickly able to produce blogs and maps and graphs and respond to queries and quickly put out information on respiratory therapists, critical care nursing, primary care, infectious disease, and critical care medicine. And so those data were quickly used by government stakeholders as well as hospitals for planning. And then the second thing that was really critical was these relationships. So not only do we sort of maintain these constant data streams, we have very long-standing relationships with legislators, policymakers, and that trusted relationship, the whole state sort of looks to us as the unbiased broker of data. And that turned out to be a great thing because we were always able to be on call. And for example, one of the things I'm going to talk about later in the webinar is the Secretary's office turned to us and said, we need you to be our liaison to the licensure bodies and to the professional associations. And we were quickly able to do that because we had these past relationships. So we were quickly able to do things like, for example, when our state needed to know how many inactive workers could we see, potentially activate, we were able to access those data quickly from the licensure boards. Or they asked us when they were putting together their volunteer workforce, tell us each regulatory body that interacts with each healthcare worker type, and we were able to produce that quickly. So those are the two things that I would highlight, Polly.
Thank you, Erin. Joanne, in California, there was a similar set of requests, if I'm correct. Can you tell us about your relationship with the state government?
Sure. Our state government also is familiar with the work that we do both in our HRSA-funded Health Workforce Research Center and then also in our larger affiliate organization of the Health Force Center at UCSF. In mid-March, we got a request for ideas to surge the workforce in California, and for that request, which came in mid-March, over the course of about 12 hours, we came up with a list of 12 recommendations, drawing from what we knew was happening in other states and our own ideas. Shortly after that, we began more substantive work for the state. One project involved working with them to guide their staffing plans for 2 hospitals the state requisitioned for expanded beds for COVID care in case of an anticipated surge of patients. For that, I created an Excel-based tool to calculate how many doctors, nurses, respiratory therapists, food service, and other staff you would need based on how many acute care beds and how many ICU beds you were trying to open. Within about 24 hours of creating that Excel file, our state agency was hiring nurses and physicians through temporary placement agencies to staff those hospitals, and one of them was open within about 4 days. That Excel workbook has supported some of George Washington University's really cool workforce deficit calculators, which Polly, I think, will be discussing in a few minutes. Our most recent project was to develop a set of resources for staffing and training in alternative care settings, which in California are aimed to provide care for COVID-19 patients who don't require acute hospital care, but also shouldn't be or cannot be in the home for some reason. So those resources are now all on our website.
Thank you, Joanne. And Jean, in New York, you all have also played a really important role. Tell us about it.
So thanks, Polly. Our center was asked to represent the State University of New York on a governor's task force that looked at strategies for building surge capacity. There was great concern that we needed more health workers than we had in the New York City area. And at the time that this task force convened, it was recognized that that's where the bulk of the cases were going to hit. So the governor had just put out a nationwide call for volunteers to help meet growing demand for health services for COVID-19 patients in the city. So we worked to help design the health professional volunteer database. And I think the idea was that we would get some basic information from, volunteers kind of raising their hands, and then we would follow up with more detailed information on what looked to be viable recruits. So in addition to designing the database, we also helped them think through the kind of interview questions they'd want to ask for those people they were considering deploying. Another thing we did was conducted outreach to state health professions associations, physicians, NPs, to ask for their assistance in soliciting volunteers or members willing to deploy downstate. Another area that we helped with was outreach to health professions education programs. So first, there was great concern that, in the middle of March, suddenly educational programs were no longer going to be able to complete clinical rotations. So there was a concerted effort to find ways to assure that there were not going to be any slowdowns in students completing training, again, in some instances with limited access to clinical facilities. So, one of the areas we looked at was outreach to both SUNY and CUNY, City University, about the things they were doing to make sure that people were completing training on schedule. And obviously the second part to that was finding ways to deploy them to high-need health facilities. So initially, Polly, those were the things that we worked with the state on.
Wonderful. So I think that these are not the only examples of health workforce research centers working with states and local governments, but they're three really interesting and strong examples of how important these centers have become to state governments. Jean, you've started talking about some of the surge strategies in New York State over and beyond the role that you all played. I wonder if you could continue along those lines and talk both about sort of the surge efforts and to the extent that there have been also efforts to sort of deregulate and make the sort of deployment of health workforce more flexible, if you will, or adaptable to the needs of the current situation.
Sure. So, again, I talked about efforts to find volunteers and deploy them. Strategies for students. I think schools and public health were part of an outreach strategy to say, if you have students, if they're in training, we'd really like to think about ways they can help. I think that, again, the effort of facilitating timely graduation for health professionals training in the state was a key priority. And in fact, most of the medical schools in New York were able to graduate their students early so they could be deployed, as well as nursing students. In the longer term, the state was also paying attention to strong support for maintaining the health professions educational pipeline, that they wanted to make sure that students were going to be able to complete their education in a timely fashion, not just now, but a year or two from now, recognizing the need for workers for the future. Another area was use of executive orders that support regulatory flexibility. Two key themes there: a relaxation of licensure, relicensure requirements, and a second one was modifying scope of practice for advanced practice nurses, PAs, among others, specifically around supervision rules. One of the things I will note is that these executive orders are all time limited. They are set to expire, and I know of at least one, I believe, around the licensure requirements that got extended, but clearly they were designed to be short-term. Probably the most interesting development has been the recognized need for better health workforce data. So currently, there's a collaborative effort that I'm involved in that include major stakeholders, hospital associations, advocacy associations, the State Primary Care Association, to pass a bill mandating re-registration surveys for all licensed health professions. I think that the pandemic brought to light how desperately we need that information. And to Erin's point, you just need it for effective planning. So at this point, we're doing outreach to the legislature to make sure they understand what it is we're looking for and how quickly we can get it. So that's pretty much what we've been up to.
Great. It would be really interesting to share that sort of that whole story, and in particular the legislation itself, with other states. I can imagine that has wings, and if New York leads the way, it will definitely be of interest to other states as well in terms of mandating this registry survey for health professions. It would be a terrific thing for everyone. So focusing in on this issue of scope of practice, particularly for the advanced practice clinicians, but of course it affects many different professions, from paramedics to scientists. I wanted to ask Joanne, who is, among other things, a specialist in advanced practice nursing, to talk about what happened in California with this push on the temporary expansion of scopes of practice as executive orders. Those in the audience probably know that this is usually done through state legislatures. So under the state of emergency, state governors were able to essentially expand scope of practice, and this is a controversial and issue, particularly with the profession not always supporting these expansions. So Joanne, the story in California was sort of interesting. Can you tell us what happened there?
Sure. California has I think, a different structure in the way that emergency orders have been able to play out. And I am not a legal scholar, but I'm sure that somebody could someday explain all the details to me about why it worked this way. So what happened in California was, of course, there were recommendations that overlapped a lot with the kinds of things Jean described. And what our governor was able to do was issue a waiver authorizing the agencies that oversee scope of practice regulations to issue waivers, and that there would be a process in place for those waivers to be requested. Under our laws, it was stated very clearly that waivers can be used to waive a regulation, but they cannot be used to establish a new regulation. So we learned that things like the scope of practice for advanced practice nurses, the way those regulations are written are along the lines of a registered nurse may do these advanced roles under these circumstances. And to waive that regulation would actually be essentially eliminating the advanced practice role entirely. So it wasn't possible for them to waive the regulations to, say, eliminate temporarily the need for physician supervision. What they were able to do for nurse practitioners and physician assistants was to waive the requirement that a physician could supervise no more than 4 at a time. And similarly, we saw different agencies do different waivers at different paces. I think the first one that came out was from our Emergency Medicine Services Authority, which oversees paramedics and EMTs. And they were straight out of the gate with a waiver on the settings in which paramedics and EMTs can practice. And but I think that their regulatory authority is such that because they are used to responding to emergencies, they were very well positioned to move rapidly and do something pretty expansive, where a lot of the other regulations, the way they were written at the beginning, created some restrictions in our ability to surge. And I think that those things will be reviewed in the future. We do have a bill. We've had a bill actually at play for about 1.5 years now to expand scope of practice for nurse practitioners. So I think that legislation will lead us to move more rapidly in the future.
Yeah, so a bit more complicated there. So Bianca, let's turn to Washington State. Washington was one of the first states, I believe, after Florida, to use a rather innovative mechanism called the 1135 waivers that are usually used for other kinds of disasters to request flexible sort of regulation from CMS on a number of fronts. Can you tell us a little about that? As I understand it, that sort of became somewhat of a road later evolved into CMS blanket waivers, but this was an innovative first step, I think, among states to request these changes.
Yeah, thank you, Polly. Thanks for this opportunity to share what's happening here in Washington State. So unlike other states where governors issued executive orders our governor goes by the route of proclamation orders, which, like Joanne said, I'm not the legal scholar here, so maybe someone can explain to me why one governor uses a proclamation over an executive order. But I think our governor actually helped to set the stage for the 1135 waivers by saying that there in this public health emergency that we needed to get healthcare workers into a role that we needed to help with the COVID crisis quickly by doing things like saying we need to allow people to come from other states to come practice in our state. And by issuing those kinds of proclamations, then our other agencies in the state are able to move quickly, knowing that there's kind of this leadership at the state level. So after that came the request from our director of our healthcare authority. The healthcare authority here in the state oversees our Medicaid program. Sue Birch is our director here, and she's really innovative and a forward thinker. So we're lucky to have her in the state. And she, with her team, wrote a letter to CMS to ask for waivers to allow this flexibility as an insurer to be able to allow healthcare workers to practice more flexibly. So in particular, among the things that were asked in this waiver were to quickly get people on board by waiving screening requirements, by asking for the allowance for out-of-state providers who comes to Washington State to actually provide care to Medicaid beneficiaries. There was a request to allow some flexibility among our providers to be able to practice across in settings that they wouldn't usually be practicing in and get reimbursed for that care. They also asked for and the pay examples of what was asked for in the 1135 waiver. And as you said, I think this helps set the stage for what other states put into place and ultimately what CMS kind of put out there as a general waiver.
Right. So an interesting sort of interplay between sort of payer waivers and state policies and understanding that interplay and how they each nudge each other along. There's an interesting policy process. So coming back to North Carolina, Erin, North Carolina is a very different state in terms of scope of practice. Clinicians, can you tell us how things have played out there in terms of this flexibility question, expansion of scope of practice?
Yeah, sure. So as you sort of alluded to, North Carolina does have more restrictive scope of practice regulations than other states. We have supervisory requirements. Nurse practitioners and other advanced practice nurses must practice under supervision of a physician. Advanced, clinical practitioners, pharmacists must also practice under supervision with a pharmacist. With a physician. And so this is an area I've thought a lot about. Is sort of how it played out in North Carolina. I mentioned that we were sort of designated by the Secretary's office to act as this liaison between her office and the licensure boards. And I can't state enough, I think, how much having a relationship in terms of with all of these health professions and having the HRSA designated Health Workforce Research Center and being recognized as impartial was critical to be able to navigate this space. So the Secretary said to us, go meet with the licensure boards, figure out, meeting with each of them, what actions do they need to be able to surge their workforce? And a lot of those were the issues that Bianca and Jean covered so well right now. And so we had these meetings, and I have to say, as a student of the health professions, it was actually really exciting because I learned things about regulatory processes that I didn't know. And we submitted a set of recommendations to the Secretary because we knew that the Secretary was asking for this because our governor, Governor Cooper, was about to put out an executive order. And we made some recommendations that would have enabled nurse practitioners to practice without supervision. We also, the Pharmacy Board, very much wanted its clinical pharmacist practitioners to be able to play a much larger role in managing chronic disease. We've spent a lot of this webinar talking about just surge response to COVID, but don't forget there were a whole set of other patients out there with chronic disease who were accessing pharmacies and really needed access to these critical medications in primary care to be able to continue to be healthy during the pandemic. And so pharmacists wanted to be able to prescribe and manage conditions for patients other than those patients that were patients of their supervising physicians. We recommended these things. Ultimately, these recommendations did not end up in the governor's executive order. And I've spent some time, as you can imagine, sort of thinking about the process and what I learned from it. And I think I'm very respectful of the fact that our licensure boards actually really right away did a lot of actions that were needed to expedite licensure, to be able to waive requirements. For example, just in the first few weeks of the pandemic, the Respiratory Therapy Board led the charge and was able to surge by 1,000 RTs by simply waiving some of their CME requirements, temporarily waiving some requirements and expediting licensure. So our licensure boards really rose to the challenge here, even though the supervisory requirements stayed in place. And I will just conclude by saying I really think, even though it didn't work out so far, but it's partly because North Carolina didn't face the same pressures as New York City, for example. We didn't have that same issue around needing excess capacity.
Interesting. Yeah, of course. So, Erin, really briefly, could you talk about the issue of telehealth? Because, of course, that in the context of the CMS waivers has been a big part of the sort of flexing the workforce and allowing the workforce to practice in different settings and in different ways.
Absolutely. Telehealth is amazing because if you think about what CMS has done recently in these sweeping changes that allow different types of health professionals to bill in different settings, including patients' homes, you end up with a situation where you quickly recognize our workforce. We have practitioners who haven't done telehealth, who are needing to learn how to do telehealth in settings where they haven't done it. And so because this is a webinar with HRSA, I really want to call out the fact that we have such tremendous opportunities to think about how to retrain our existing workforce around telehealth and particularly around team-based delivery of telehealth. But we also have enormous opportunities and challenges around trying to figure out how to train our pipeline, our medical students, our nursing students, our pharmacy students around the use of telehealth. And so I think that it'll be fascinating to sort of think about how this plays out. If these changes in these reimbursement for telehealth remain in place post-pandemic, what changes do we need to see in Title VII and Title VIII funding around telehealth, and what is HRSA's role here is really what I would emphasize, and happy to talk about that in the Q&A.
Yeah, great questions, Erin. Super interesting. Obviously, areas for all of us to be thinking about research questions in the future.
Absolutely.
So, Angela now, and I've left Angela for the second half of this webinar, but it's a really important issue is not only the insufficient PPE, which everyone has been talking about, but also the issue of trauma to our healthcare workforce, and the issue of the sustainability of the behavioral health workforce providers themselves, given that they have had to change the way they practice as well, probably doing much more telehealth, among other things. But Angela, your center focuses on the behavioral health workforce. Can you tell us a little about what's happening, both in terms of the support for the healthcare workforce sort of more generally, and also in terms of how can we shore up the sustainability of our behavioral health?
Sure, thanks, Polly. The need for mental health and substance use disorder services has certainly spiked as there are many consequences of COVID-19 that can take a toll on mental health and wellness. And I want to draw attention back to that graphic that was shared in the chat box that shows that fourth wave. So we expect mental health needs to continue to rise long after the public health emergency is declared over. Similar to the strategies that have been discussed for the broader health workforce, things like modifying funding and reimbursement regulations and scopes of practice, state licensing regulations around things like telehealth to permit work across state lines is important for the behavioral health workforce to adjust to this increasing demand. This is a workforce that was already in a state of undersupply and had poor distribution of workers pre-COVID. So the regulatory changes are really important to maximize use of the providers that we have. With regard to your question about well-being of the health workforce, we're certainly concerned about burnout and presentation or exacerbation of mental health conditions, particularly for those working on the front line. A recent study of Chinese healthcare workers exposed to COVID found that a considerable proportion of respondents reported symptoms of depression, anxiety, insomnia, and distress. And it also found that nurses, women, and frontline workers were among those who reported more severity across all of those measures than other respondents. So we need effective behavioral health interventions for our healthcare providers, and we need sufficient workforce capacity to support those interventions.
Excellent. Bianca, I know that your center has been tracking furloughed workers with a level of granularity within the state of Washington that is excellent, but also at a national level with some less level of detail. Interesting nonetheless. Can you tell us what's happening with your furloughed workforce?
Yeah, thank you for bringing up that issue. So there are definitely two separate issues, but very related. So as many of you have seen in the news, many healthcare workers are getting furloughed. It's happening across the board in all settings. And I think we're just starting to see what furloughs are going to look like for healthcare workers. I think early on in the pandemic, we're at least using data here from our Employment Security Department, who processes unemployment claims. We work very closely with them to get data from them to track unemployment by different occupations. And early in this pandemic, we have seen huge drop-offs in employment for our oral health workforce. But we're seeing this kind of permeate over time as more mental health services are laying off workers because there are not as many people coming to get care, as well as our primary care clinics, obviously, too, which have closed services. And as we look forward, I mean, we're starting to hear academic medical centers having to lay off workers just to keep up and deal with their finances and keep themselves as revenue neutral as they possibly can. And this, of course, takes a toll on our healthcare workers. I mean, while we're tracking data very closely here in Washington State, this is clearly happening across the country. And there's a sense, if you read various stories out there, that healthcare workers are feeling like they're commodities, that they can just be let go at a time when we know that they're so critical. And we're doing what we can here in the state to figure out how do we redeploy these unemployed healthcare workers to put them into places where we know they're so critically needed. And again, try and figure out what can we learn here at the state level that we can also apply nationally. We're realizing that there needs to be a better redeployment mechanism, some better coordination that happens to help do this warm handoff of finding those people who are filing for unemployment, who are healthcare workers and have the skills to go back into healthcare jobs where we most need them. Usually right now it's really in long-term care. But a big barrier in all this that we haven't really talked much about is the important role of PPE, or personal protective equipment, which is so needed for people to feel okay to get back into work, but also for patients to feel safe that when they see their providers that everyone is being protected. And without that in place, I think we're going to continue seeing healthcare slow roll back into business, and so that will probably extend the furloughing of workers, and I think continue to make healthcare workers feel, you know, not as appreciated as I think we want them to feel. And I'll just add to this, unfortunately here in Washington State, and again, I'm sure it's not just to us, is that we're seeing fraud happen where, and unfortunately it happened to me too, which is that fraudulent unemployment claims are being opened up by people under people's names, and many of our own healthcare workers in our own medical system at UW Medicine are finding this to be happening. And this is just adding insult to injury, and unfortunately also adding noise to our data around furlough of healthcare workers. So lots of things still need to be worked out, but I think this is an area that we need to pay attention moving forward, is how do we make sure that our healthcare workers are feeling safe, that they're showed that they're appreciated, and how do we do that? How do we do that better? How do we track this information better to make this all happen?
Right, and of course this is especially concerning when you think about incoming students in the health professions and what kind of message they may be receiving about their job security going forward. So I know that a lot of people have been concerned about the pipeline and what the implications of this furloughing is on the level of enthusiasm for people going into the health professions. So I wanted to just spend the last 5 minutes before we open up for questions pointing out that in addition to the initiatives that many of you have already mentioned, the Health Workforce Technical Assistance Center has a terrific website that is essentially a one-stop shop for what all of us are doing in our different health workforce research centers. So obviously each of us has our own website and their own, promoting our own activities and our own tools and our own studies. But most of it, I believe, has been centralized as well in the TA Center. So thank you, David, for doing that. That saves folks a lot of time when they want to have access to the work that we're doing. I would just say if anybody has any initiative that has not been mentioned thus far that they wanted to call out, we have a couple minutes for that.
Hi, Polly. This is Erin. Really fast. Sure. Our legislature just passed a bill which requires the NorthCon AHEC in conjunction with us and the IOM to conduct a pandemic workforce study. Lessons learned in terms of the state response, and that response is how well we did in acute care, ambulatory primary care, nursing homes, adult care homes, correctional facilities, and in-home care. So as we learn what we did well and didn't do well, happy to share that with others. Just delighted the legislature has asked us to do that. Hopefully there'll be some good learning.
Fascinating. What's the timeline on that, Erin?
It's about, we have to report in about a year and then action within the next following year.
This is Bianca. I'd like to just share one thing that some of you may be familiar with already taking place here in Washington State. We have developed something called the Sentinel Network, and which has been supported by our state government. It's funded on a regular basis now for data collection of our healthcare providers across the state, specifically healthcare employers, to tell us what are the health workforce challenges that they're facing. Before COVID, we were already tracking questions like which areas are you facing shortages, where are there prolonged vacancies, why do you think that there are barriers to recruitment? And we've modified the Sentinel Network to have COVID-specific questions to have people tell us a little bit more how COVID is affecting this. And so we've now posted several short briefs about what oral health providers are feeling, what our long-term care facilities are feeling, and as well as our behavioral health clinics are feeling, because these are places that don't usually have very good outlets to express what's happening to them. So we're finding this to be a very useful tool in Washington, and I would love to see this and love to share how we can do this in other states.
That would be a great model for others to copy. Angela, I know you've had a little bit less time to talk about your work. Was there anything you wanted to mention before we go to the open questions?
Sure. The work that our center is doing is really trying to estimate what that demand might look like after we're through with crisis response and into crisis recovery, and specifically looking at behavioral telehealth in that context. As was mentioned, so many of the regulatory changes have this expiration timeline that tends to be tied to during the state of the emergency. So we really need to have an evidence base around what's changed, what's working well now, and what should be sustained after COVID is contained to maximize workforce capacity.
And if I may, I would just mention a couple things that we're doing at GW as well. We have a webinar series. We have about 15 webinars that are focused on emergency health workforce policies, including drawing on lessons from the state, but also federal policies. And you'll find those on our website. And then we've produced two tools. The first is on the hospital health workforce and is intended to be used by states. We've done 5 professions thus far, and we're modeling the demand based on IHME's projected peak of hospitalization. So we are hoping that we've turned the corner in terms of these peaks, but it was an interesting exercise. You can click on any state and essentially plug in your own staffing ratios and your own attrition rates for the workforce and see whether there's a significant gap in terms of those professionals for COVID patients as well as for what you would need for non-COVID patients. And then we have a tool that is focused not only on state decision makers, but also local health department decision makers who are trying to figure out how to staff up for contact tracing. So the contact tracing workforce tool also allows users to modify parameters based on whether they're doing it by telephone or in person, what kinds of needs the population has, and the extent to which contact tracers also need to be addressing social services kind of issues and care coordination kind of issues, whether they have technology in place to actually track people. All these variables, of course, affect the workload and therefore the numbers of contact tracers you need. So this is a tool that's being used widely. We've had a lot of local governments contact us with interest in using it, and actually several countries outside of the United States interested in using kind of a blank Excel sheet to plug in their own numbers and begin to use this as a way to estimate their own needs. So I think the mechanism for open questions should be the chat box. If you all can type in questions, we'd love to try to answer them. And if there are no questions, we have lots more that we can think about talking about. But I'll open it up in the hopes that some of you have issues that you'd like us to focus on. Well, in the interim, while we're waiting for questions to come in, I'm not seeing any. Jean, do you want to mention anything in terms of the additional activities that you're doing that you haven't described thus far?
Sure, Polly. So the Health Workforce Technical Assistance Center is actually collaborating both with GW and UW to do exploratory studies, one on state strategies to build surge capacity. And I think it's a combination of what did they try, and to the extent we can ascertain it, how well did it work? And we're also interested in looking more at the issue of worker furloughs. Who got furloughed? What happened? When? When or if did they get called back? Were they deployed as part of surge capacity? So again, just trying to understand the changes that were happening in states around how health workers were used, deployed, et cetera. Another area that we're looking at is oral health. We think that oral health service delivery is going to undergo some pretty substantial transformation. And so a couple of areas that we want to look at are the extent to which dentists and hygienists were actually deployed to medical settings to provide care during the pandemic, and then again, what the consequence of what happened after that. And a second study looking at dental safety net providers. I think that oral health is really needing to think through a lot of new and different strategies for the delivery of oral health services, probably with more focus on prevention and less invasive treatments. But again, I think that it will be important to learn more from provider communities about what they're doing. And we imagine doing this in collaboration with the Health Policy Institute at ADA, as well as the National Association of Oral Health Providers that based at FQHCs.
We have a great webinar that we just did on oral health that would help to tee up some of these issues as well.
I heard it.
Some of the partners.
It was great. It was great.
Great. So we do have a question here on resources what can we point clinical sites to in terms of resources for promoting provider resiliency? And Joanne has offered to take a stab at this question.
Yes, so this is something where we have been helping to crowdsource ideas around this, some of which are posted on our website. And then, of course, we know that the Technical Assistance Center has things on their website. One of the resources that is coming online that I think might be really interesting and useful is I got approached by somebody at the Medical Association of Georgia who I think then probably spoke with nearly all of the workforce center directors plus other experts from around the country. They wanted to develop a one-pager on how leaders in healthcare organizations can prepare to sustain and support their own workforce with the stress and the resiliency issues around COVID-19. So, I know that they drew from a number of the resources that are on the CDC website, the various professional organizations that focus on behavioral health and so on. And what they wanted to do was try to distill all of these ideas down into something really short and sweet. So that is linked up on our website, and I think there are, I mean, the challenge is there are so many resources that it can cause you a behavioral health crisis just trying to read them all, because there's too much. And so anything that we can do to help distill this down, please ask us. And we all, I think, as a collective group, would be happy to point you to what we've seen that's helpful.
Right. So we have a technical question. What happens with the physicians that are holding visas, so the IMGs, and if they're furloughed, presumably, their visa is in danger. And what the question is, what the long-term impact of that may be. Does anybody have information about what's happening with the J1s or the H-1B visas if folks are furloughed?
This is Erin.
Bianca, I don't know that. Yeah, I was going to say Erin probably would be the best one to speak to this.
No, go ahead, Bianca. Unless you were just going to.
No, go for it.
This is an issue that the Council on Graduate Medical Education is considering in collaboration with ECFMG. There are a number of issues here, and there will be a need to really understand visa requirements and how they interact, not only with furloughed workers, but there were questions regarding need for surge, and in fact, whether those people who either were unmatched or were IMGs or who had visas or wanted visas, didn't have visas. There's a whole set of questions here more broadly on how we appropriately utilize our foreign-trained workforce, not only of physicians but other healthcare workers as well. So COGME is looking at this directly, and we'll have some recommendations.
Good. So the next question is with regard to the role that HRSA should be playing in telehealth training, and whether any of our centers have thoughts on the kind of training in this space that would be useful for HRSA to do. I mean, it sounds as though many of the academic associations would be eager to have a conversation on this. I know I serve on the Health Policy Advisory Committee for the American Association of Colleges of Nursing, and there was a conversation just yesterday about how, there are huge disparities in terms of schools that were able to or have already been providing training in this area, and also have been able to pivot and provide distance learning, which is sort of a version, if you will, of tele-education, but prepares people well for telehealth as well. And recognizing that the small schools, particularly the community colleges, the trained nurses are not necessarily well equipped to do this. So I think the conversation has begun among the academic associations, and it would be interesting to think about whether there could be some interprofessional initiatives in this area so that it's not siloed, since, as Erin mentioned, telehealth in a sense is an opportunity to begin to rethink teams and some shifting of who does what. But it's a really good topic for all of us to be thinking about in the future, no doubt.
Yeah, I was going to say that also I think that many of HRSA's training programs already may be well suited to kind of bring in telehealth training opportunities. For example, the GWEP programs, the Geriatric Workforce Enhancement Programs, are locally based community, kind of multi-professional, and often have service providers engaged in their work. And they are in a possibly very good position to build into some of their collaborative work telehealth aimed at the older populations that they serve, many of whom have very specific issues with respect to telehealth use from the patient side. So I would imagine that many of the HRSA programs are already well positioned to provide funding mechanisms and support for the various organizations that are excited about both training new entrants to the workforce as well as retooling current professionals to be better able to use telehealth.
This is Jean. I just want to say that I think this is an extremely important thing that we need to think about, and we need to find ways to provide information to people about best practices or conduct evaluations that people can identify the most effective approaches. So again, I think it's an emerging area and requires a good deal of attention.
I think we're realizing that telehealth has its limits. At some point in time, I think clinicians feel like they still need to touch and feel a patient. And I think understanding where telehealth works really well and where there may be gaps is important to really understand better. And I think it needs to go beyond just the telehealth platform, because there are a number of digital health tools that were emerging before COVID and perhaps have been identified as very useful tools to clinicians to get more of that feel and touch, building off the sensors that are starting to appear in people's homes that we can work off of to be able to better understand vital signs and things like that may be a potential substitute for being in person. I think there's just more that could be done to better understand how digital health technologies are linking into telehealth and what kind of gaps they are or are not able to fill for clinician needs.
Great point, Bianca. And of course, all of this is going to be really interesting to see, particularly in primary care, how much we return to the world prior to COVID and how much we end up really modifying the way care is delivered for certain kinds of services forever. So everyone, I think, will be tracking that and trying to understand what the change is that's happening going forward. So, well, I wanted to thank all of you for your incredible insights and for the work that you're doing, and to thank Dr. Padilla and Michelle Washko for inviting us to do this webinar, and thank Dave as well for organizing it. I think we will sign off. Thank you all.
Thank you for watching the webinar. To view our extensive webinar library and other helpful resources, please visit us at healthworkforceta.org.